Let's now start with the chapter 53rd of your Apurba Sastry Essentials of Microbiology, which is about gas gangrene and infections due to non-sporing anaerobes. In this chapter, we'll be previewing the Clostridium infections, Clostridium perfringens infections, and non-sporing anaerobic infections. In this video, we'll be covering the pathogenesis of Clostridial infection and the Clostridium perfringens infection, while the lab diagnosis and non-sporing and aerobic infections will be covered in the subsequent videos. Introduction. Anaerobic bacteria do not have cytochrome system for oxygen metabolism, hence are unable to neutralize toxic oxygen metabolites. Therefore, they either cannot grow in the presence of oxygen, obligate anaerobes, or do not neutralize oxygen but tolerate its presence, aerotolerant anaerobes. Anaerobes need special requirements to grow in culture such as anaerobic conditions. This can be achieved by various methods such as Macintosh and Filde's anaerobic jar, gas pack system, axonomat system, anoxomat system, and anaerobic glove box workstation, pre-reduced anaerobically sterilized media. Medium with low redox potential. This can be achieved by adding to the media with reducing substances such as unsaturated fatty acids, ascorbic acid, glutathione, cysteine, glucose, sulfites, and metallic iron. Obligate anaerobes can be grouped into spore bearing, example Clostridium, and non spore bearing anaerobes, described later. Clinical presentation of anaerobic infections. Anaerobic infections are associated with various clinical clues such as infections adjacent to mucosal surface that bear anaerobic flora, predisposing factors such as ischemia, tumor, penetrating trauma, foreign body or perforated viscus, spreading gangrene involving skin, subcutaneous tissue, fascia and muscle, foul smelling, putrid pus, abscess formation, septic thrombophlebitis, toxemia and fever not marked. Failure to respond to antibiotics that do not have a significant anaerobic activity. Organisms are seen under gram stain but fail to grow in routine aerobic culture. Special features may be observed such as gas in specimen, gas gangrene, black metal pigment that fluoresces, Pervotella melanogenica, and sulfur granules actinomyces. Lab diagnosis of anaerobic infections. Specimen or clinical specimen for anaerobic culture must be handled meticulously as brief exposure to oxygen may kill obligate anaerobes and result in failure to isolate them in the laboratory. Accepted specimen, tissue bits, necrotic material, and aspirated body fluids or person syringes. Unacceptable specimen, all swabs, sputum, or voided urine. Specimen should be immediately put into RCM broth or other anaerobic transport media and brought to the laboratory as soon as possible. Robertson cooked meat or RCM broth is the most commonly used anaerobic media. It contains chopped meat particles, beef heart, which provide glutathione and unsaturated fatty acids, which take up oxygen and create low redox potential and thus permit the growth of obligate anaerobes. Microscopy. All clinical specimens from suspected anaerobic infections should be gram stained and examined for characteristic morphology. Culture identification. Samples should be processed immediately under anaerobic condition, which can be created by various methods as described earlier. Culture. Various culture media can be used for the isolation of anaerobes such as anaerobic blood agar and neomycin blood agar, egg yolk agar, phenyl ethyl agar PEA. In these figure A to C, we see the Robertson cooked meat broth. A shows uninoculated broth. B shows pink and turbid Clostridium perfringens inoculated broth. And C shows black and turbid Clostridium tetani broth. BHIS agar, brain heart infusion agar added with supplements such as vitamin K and hemine. Bacteroides bile esculin agar BBE agar. Identification of anaerobes is based on biochemical test, susceptibility to antibiotic disc, gas liquid chromatography, automated systems such as Malditov. Anaerobic infections. Common antibiotics given for anaerobic infections are metronidazole plus penicillin, drug of choice for odontogenic infections. Carbamazepines, example meropenem. Beta-lactam or beta-lactamase inhibitor combination amoxicillin, calvinate, piperacillin and tazobactam, clindamycin in case of penicillin allergy. Choice of antibiotics depend on the site of infection, severity of infection, type of anaerobe involved in the susceptibility to antibiotics. Antimicrobial resistance in anaerobic bacteria is an increasing problem. Now coming on to Clostridial infections. Clostridia are gram-positive bacilli having bulging spores in contrast to genus Bacillus which has non-bulging spores and encompass more than 60 species. Clostridia are saprophytes found in soil, fresh water, marine water, decaying vegetation, animal matter and sewage, thus play a major role in recycling of organic matter. They are also harbored in intestine of vertebrates and invertebrates including human beings. However, few members may cause a variety of infections in humans such as Clostridium perfringens causes gas gangrene and edematous myonecrosis like condition. Clostridium tetani causes tetanus mediated by neurotoxin tetanus toxin which causes skeletal muscle spasm and autonomic nervous system disturbance. Clostridium botulinum produces a powerful neurotoxin called botulinum toxin that causes botulism. Characterized by flaccid paralysis of muscles, it presents in three clinical forms: food poisoning, wound infection, and infant botulism. Clostridium difficile causes pseudomembranous colitis in hospitalized patients who have a history of prolonged intake of broad spectrum antibiotics. Spore. In Clostridia, the spores are wider than the vegetative bacteria, giving rise to swollen or spindle shaped appearance. Clostridium is named from the word "closter", meaning spindle. Spore formation occurs in unfavorable conditions. Most of the Clostridia bear a subterminal spore, Clostridium perfringens, except Clostridium bifermentans produce central and oval spore. Clostridium tetani produce spherical and terminal spore, drumstick appearance. Clostridium tertium produce oval and terminal spore, tennis racket appearance. In RCM broth, Clostridia grow in well in RCM broth, producing turbidity in the medium and may be of two types. Proteolytic Clostridia turn the meat black and produce foul odor. Example: Clostridium tetani, Clostridium botulinum A, B, and F. Saccharolytic species turn the meat pink. Example: Clostridium perfringens, C. difficile, and C. botulinum, C, D, and E. Now coming on to Clostridium perfringens infections. Clostridium perfringens, previously called as Clostridium welchii, is a common cell in the large intestine of human beings and animals. It is also found as saprophyte in soil, dust, and air. It is capsulated non-motile gram-positive bacillus. It bears subterminal bulging spore but does not produce spore in tissues or in culture media, especially the gas gangrene strains. It is invasive as well as toxigenic. Types of spores: oval and central spores of Clostridium bifermentans, subterminal spore of Clostridium perfringens, spherical and terminal spores of Clostridium tetani, and oval and terminal spores of Clostridium tertium. Virulence factors. The virulence factors produced by Clostridium perfringens can be grouped into four different types. Four major toxins: alpha, beta, epsilon, and iota. Eight minor toxins: gamma, delta, lambda, kappa, theta, eta, mu, and nu. They also produce heat labile enterotoxin. Soluble substances are produced such as neuraminidase, histamine, bursting factor produce muscle lesions, and circulating factor inhibit phagocytosis. Clinical manifestations: Clostridium perfringens infections are mostly polymicrobial involving other Clostridia species. Various manifestations include Clostridial wound infections. McLennan has classified them as follows. Simple wound contamination involves the wound surface contamination without invasion of underlying tissue as occurs in absence of devitalized tissue. Anaerobic cellulitis involves the facial plane with minimal toxin release without muscle invasion. Anaerobic myositis gas gangrene muscle invasion occurs which leads to gas in the muscle compartment with abundant toxin release. Clostridial enteric infection. Food poisoning. It is caused by Clostridium perfringens type A enterotoxin coded by CPE gene. It occurs following consumption of improperly cooked contaminated meat. Spores bearing heat resistance and survive and germinate later when food is cooled. Infective dose: about 10 to the power 8 viable vegetative bacilli producing enterotoxin are required to initiate the infection. Enterotoxin acts by forming spores in the intestinal mucosal membrane. Diagnosis by detection of enterotoxin in feces by enzyme immunoassay. Enteritis necroticans, gas gangrene of the bowel. It is life-threatening condition characterized by ischemic necrosis of jejunum and gas in the tissue plane. It is also called known as pig bell in Papua New Guinea and Diarrhea brand in Germany. It's caused by Clostridium perfringens type C strains producing beta toxin. Necrotizing enterocolitis resembles enteritis necroticans but is associated with Clostridium perfringens type A and has been found in North America. Gangrenous appendicitis is also done. Other clostridial infection, bacteremia, Clostridium perfringens followed by Clostridium tertium and Clostridium septicum are commonly associated with bacteremia. Skin and soft tissue infection, Clostridium perfringens, Clostridium histolyticum, Clostridium septicum, Clostridium novae, and Clostridium sordelli cause necrotizing infection of the skin and soft tissues. Infection of the endometrium leading to toxic shock syndrome can be associated with Clostridium sordelli. Meningitis and brain abscess, panophthalmitis due to Clostridium sordelli or Clostridium perfringens. Gas gangrene. Definition by Oakley in 1954. Gas gangrene is defined as a rapidly spreading edematous myonecrosis occurring in association with severely crushed wounds contaminated with pathogenic Clostridia, particularly with Clostridium perfringens. Previously, the disease was called as malignant edema or clostridial myonecrosis. Etiological agents. Gas gangrene is always polymicrobial and is caused by many clostridial species. Established agents. Clostridium perfringens, most common 60% of the total cases, and Clostridium novae and Clostridium septicum 20 to 40%. Probable agents, they are less commonly implicated. Example, Clostridium histolyticum, Clostridium sporogenes, Clostridium falix, Clostridium bifermentans, Clostridium sordelli, Clostridium aerophytidum, and Clostridium tertium. Pathogenesis, the development of gas gangrene requires an aerobic environment, crushing injuries of muscles such as road traffic accidents causing laceration of large or medium sized arteries, open fracture of long bones or foreign bodies, bullet injuries, or devitalized tissues leading to interruption in the blood supply and tissue ischemia. Anoxic muscles start utilizing pyruvate anaerobically to produce lactic acid. Contamination of wound with Clostridial spores present in the soil during war or road traffic accident or clothes. Rarely, spontaneous non-traumatic gas gangrene occurs via hematogenous seeding of normal muscle with bowel clostridia as occurs in people with gastrointestinal pathologies, example colonic malignancy. Virulence factor mediating gas gangrene toxin produced by Clostridium perfringens once introduced by C. perfringens proliferates locally and elaborates toxins, exotoxins, chiefly alpha and theta toxin. Alpha toxin is the principal virulence factor, has both phospholipase C and sphingomyelinase activities. It activates the platelet adhesion molecule GP2B3A and neutrophil receptors CD11B, CD18, leading to formation of aggregates of platelets and neutrophils in the blood vessels, causing occlusion. Alpha toxin directly suppresses myocardial contractility, leading to reduction in the cardiac output and results in profound hypertension. Theta toxin caused marked vasodilation by activating mediators, example prostacyclin, platelet activating factor. Toxins produced by other Clostridia. Clostridium septicum produces four major toxins: alpha toxin, letha, hemolytic, necrotizing activity; beta toxin, DNase; gamma toxin, hyaluronidase, and septicolysin protease and neuraminidase. C. novae has four subtypes A to D. Type A produces bacteriophage coded alpha toxin, which commonly causes gas gangrene. Clinical manifestation of gas gangrene. The incubation period is variable depending upon the nature of injury, the amount of wound contamination, and the type of Clostridium species involved. The incubation period varies. For example, 10 to 48 hours for C. perfringens, 2 to 3 days for C. septicum, and 5 to 6 days for C. novae. Various manifestations include sudden onset of excruciating pain at the affected site, rapid development of a foul smelling, thin, serosanguinous discharge, gas bubbles, crypticus in the muscle planes, brawny edema and induration, Such gangrenous tissue later may become liquefied and sloughed off. Shock and organ failure develop later, associated with higher mortality rates. Okay, so this completes our part 1 of the chapter. The lab diagnosis and the other infections will be covered in the next videos. Okay, like, share, subscribe. Thanks for watching.